Okay, so your bronchodilators, these are going to be indicated for use to treat COPD and asthma because they are opening up those bronchioles. There are three major classes of bronchodilators. Two of these we've talked about before. Your sympathomimetics, like your beta 2 agonists. So they're going to stimulate those beta 2s, which is going to cause your bronchodilation. Also, your anticholinergics, and so they block those muscarinic receptors, so they're antagonistic to the muscarinic receptors, which cause bronchoconstriction, and so if it's not constricting, then it's going to stay open, i.e. dilated, right? And then we have our methylxanthines. Xanthines are like caffeine, right? And these can relieve constriction. So while these two you will find rescue inhalers. They can be rescue inhalers. With these are not typically in the rescue inhaler, but they are called relievers. And so after the constriction has happened, you can take these, and they're slower acting, but they also act longer. And so the way this all works is your beta agonists are going to bind the beta 2 receptors, which is going to activate the production of cyclic AMP or CAMP, which causes bronchodilation. Then your xanthines will inhibit this to keep up your cyclic AMP. And so this enzyme breaks down cyclic AMP. And acetylcholine will bind its muscarinic receptors and cause bronchoconstriction. And so your muscarinic antagonists stop that from happening. Also, your xanthines will interfere with adenosine, which also can cause bronchoconstriction. Your xanthines are also CNS stimulants and kind of work in the same realm as this, working on those receptive centers in the brain. So it's multi-pronged approach with theophylline, which is a methylxanthine. So beta adrenergic drugs, definitely not the first time we talked about beta adrenergic drugs, but typically we've been talking about beta 2s or beta blockers. And this one we're talking about beta agonists. There are two major classes of your beta agonist. You have your non-selective and your selectives. With your non-selectives and your selectives, both of them are going to increase that cyclic AMP, causing your bronchodilation. Some of them also inhibit mast cell release, which is beneficial because we know histamine can cause the bronchoconstriction, right? Problem with the non-selectives is they also act on the beta 1s and can raise your heart rate. Your selective 2s, we kind of see a little overlap, but there's little to no cardiac effect. So with selective beta 2s, when you take them, you might feel a little jittery. It might increase your heart rate a little bit, but nowhere near as much as your non-selectives. Types of non-selectives, we come down here. Epinephrine, isoproterenol. Your selective 2s, albuterol. Your selective 2s are really the go-to for asthma and COPD, especially in your rescue inhalers. On to our methylxanthines. Xanthines we talked about before. Things like caffeine, theophylline, theobromine. These are naturally occurring. You find them in coffees, teas, also cocoa, dark chocolate has a lot. Mild stimulation of the central nervous system. Sometimes, especially like in preemies, if they can't control their own respiratory rate, you can give them caffeine. And that caffeine stimulates those respiratory centers in the central nervous system to keep them breathing. But we also see effects on the heart, the kidneys, bronchodilation, increased skeletal muscle tone, and contraction strength. And so sometimes your methylxanthines can be used as performance-enhancing drugs. But theophylline is the only one that is indicated for use in asthma and COPD. So what it does is it inhibits phosphodiesterase, which activates CAMP. And so we're stopping the thing that breaks it down. We're going to have more of it around, which is going to lead to bronchodilation. Side effects include nausea, vomiting. Also could cause vasodilation with flushing in the face and headaches. Our anticholinergics, acetylcholine, when it binds its muscarinic receptor, causes bronchoconstriction and also mucus secretion. And so if you want to decrease mucus secretions, especially in like cystic fibrosis or a lot of your COPDs, you can use your anticholinergics, and they help with that. It's only indicated when the other bronchodilators are contraindicated. And so that means you don't typically use an anticholinergic unless using a beta-2 agonist or a beta agonist and or a methylxanthine is going to cause other problems. Or if you're already on one of those and it's not working well enough. So if you need an additional bronchodilator, it works. Impartropium bromide or Atrovent is kind of the go-to for your anticholinergics, also Spiriva. Both of them are derived from atropine, which is a muscarinic antagonist. They give you side effects like dry mouth, but really, since these are inhalers, they're supercharged, and so they don't really cross the border in the lungs, and so they don't get into the blood supply, and so you don't have it making into the systemic circulation, and you don't have a lot of those systemic side effects, typically dry mouth. And to get rid of that, just rinsing the mouth after you have taken the inhaler will help with that. We can also use anti-allergic drugs. We talked about it last time. Cromolyn sodium interferes with that antigen-antibody reactions of your mast cells, so you're not having that whole inflammatory response. Omalizumab is also an anti-allergic drug that we didn't talk about last time. So what it does is it's an anti-IgE monoclonal antibody. What that means is it is an antibody that is created to bind an antibody. And so it binds and inactivates your immunoglobulin E's. Then, kind of in a similar, it's important in respiratory pharmacology. It's going to be your mucolytics and your expectorants. So these are things that are going to break up mucus and help you expel the mucus from your chest, right? So mucolytics, they liquefy those bronchial mucus so that mucociliary escalator can work better, right? Acetylcysteine or mucocil contains sulfhydryl groups that get in there and break up the glycoproteins that you find in mucus, decreasing the viscosity, so making it more runny. Easier for the escalator to move it, easier for you to cough it up. Expectorants also help by, one, breaking up the mucus a little bit more and also lubricating it. They contain salts like ammonium chloride, potassium citrate. Mucinex is a type of expectorant. Your expectorants can be over the counter. You can get Mucinex anywhere, right? And that is it for our respiratory pharmacology.